Hi, good afternoon. Thanks to everyone for taking the time out to be here today. We really appreciate the opportunity to speak to everyone on this kind of a level. I recognize a bunch of people out there, so I want to thank you personally for being here. It means a lot to me, so thank you. So we're going to be talking about CA125, and I know this is something you know a lot about personally. We're going to dig deep, a little bit deeper than the usual discussion about it. So we're going to understand a little bit more about what CA125 is and what it isn't. So what are the limitations to the test? We're also going to talk about when we use it and why. I'm going to spend a little bit more time today on screening than I usually do, and the reason for that is a really large screening trial just got published with some interesting results, so I want to go through that so you understand them well. And then we're going to spend some time talking about how you can interpret your CA125 results. So, thankfully, ovarian cancer is not that common. Only about 1 to 2% of women in this country will be diagnosed with ovarian cancer, so it's not nearly as common as breast cancer, lung cancer, or colon cancer. But unfortunately, ovarian cancer has a very high mortality rate. Ovarian cancer was not on the prior slide, right? It didn't hit the top 10, but unfortunately, it's number 5 in the cause of death for women in this country. And the reason for that, unfortunately, it's not because it's a particularly virulent disease. It's actually relatively chemosensitive. We have lots of good treatment for it, as Dr. Levine talked about. The problem is that we are diagnosing it way too late, right? So the majority of patients get diagnosed when they are stage 3 and 4. And what that means is that instead of being limited to the ovaries, the disease has already spread throughout the abdomen and perhaps even farther. So when we have that many cells to deal with, we have a much harder time eradicating them with surgery, and then we give our chemotherapy a much more difficult job to eradicate whatever residual cells are left. Patients who are at stage 1 have a far better survival rate than patients who are stage 3 and 4. So what if there was a way for us to identify this cancer early? Not surprisingly, that was a very strong area of research for many years. So what CA125 is, it's actually what we call a glycoprotein. So it's part protein, part carbohydrate, and it lives along the cell surface. And you can see it kind of sitting out there. It's a relatively large molecule. Interestingly, we really don't know what it does. We know where it lives. It lives in the reproductive tract. It lives in the respiratory tract, so we see it in the lungs. And it also is found in the eye. But we're still not sure what its complete function is as a molecule. They've done studies, and they see that if you have an increased amount of mucin 16, you have a decreased likelihood of infection. And it also seems to help with the movement of cells. We call that cytoskeleton motility. So many years ago, back in 1981, Dr. Bob Bast, a very prominent researcher in our field, remains so to this day, was testing different proteins on ovaries to see if any of them he could make an antibody to and identify that antibody ultimately in the blood with women with ovarian cancer. He was a very persistent man, thankfully, because it wasn't the first time he tried or the second time, but the 125th try was when he landed on this correct protein. And so that's why it's called cancer antigen 125. So be persistent is what that, says everybody. So here's what it looks like. This is actually from the original paper. And that's just a long list of different types of cancer cells. And the box that I've highlighted shows that the top 6 cancer cells are all ovarian cancer cell lines, so different types of ovarian cancers, like Doug was alluding to. And all of them bound very well to this new antibody that Dr. Bast found. Conversely, all of the other types of cancers, the non-ovarian cancers, did not bind well at all, except for one melanoma that had some weak binding. So this was really revolutionary. It meant that finally there was a test we could use that possibly could allow us to follow patients with ovarian cancer. This opened up a lot of doors, right? So all of a sudden, can we screen patients with ovarian cancer, right? So can we find disease earlier? We can help determine which patients who present with an ovarian mass, how many of them should be concerned. In patients who we know they have ovarian cancer, we can then help guide them through the course of therapy and potentially find out sooner when their cancer recurs. And also it can be very helpful from a research standpoint in terms of clinical trial design. Is there another way for us to determine if people are recurring earlier and perhaps spare them toxicity of drug and switch them to a new agent relatively early? As you already know, CA125, although is a major step forward, has a lot of limitations. If it didn't, I wouldn't be giving this talk. So we're going to spend a lot of time talking about what CA125 can't do. So this is actually from a meta-analysis that Dr. Bast did with another colleague. And this is an old study, actually, but even back then, so in the years after, immediately after the initial discovery of CA125, multiple other researchers went to try to determine whether or not this could be supported further. And they found a few limitations right off the bat. One is that if you go by the stage at diagnosis, there's a big variation in terms of who's likely to have a positive CA125. So here, I'm trying to get this to work. If you're stage 1, you're only going to have an elevated CA125 50% of the time. So that's not very helpful in terms of our hopes of finding something that's going to identify women early. Even if you have advanced cancer, not all patients are going to be identified. Here the number is 94%, and in other studies that number is actually lower. Also, the different subtypes of ovarian cancer do not have the same likelihood of having an CA125. So, if you have serous cancer, you're most likely to have an elevated CA125. So 80% of patients with serous cancer have high CA125 levels. But if you have a mucinous or endometrioid type cancer, you're much less likely to have an elevated CA125 level. So there's variation across the board. So this diagram looks at a lot of different tumor markers together. And CA125 is noted in 4 different areas. So like I said, it's not just the reproductive tract, but the respiratory tract also produces mucin 16. So CA125 can be found as elevated in lung cancer. It's actually been elevated in breast cancer, in pancreatic cancer, and in ovarian cancer. So it is not completely limited to ovarian cancer diagnoses. But more concerning, perhaps, is the fact that there are a multitude of non-cancer conditions that elevate your CA125. Endometriosis is relatively common, happens to about 15% of reproductive age women. That's when part of the uterine lining gets transplanted out into the abdominal cavity just through normal menstruation. And the presence of endometriosis is well known to elevate your CA125. Myomas or fibroids can elevate your CA125. An infection, pelvic inflammatory disease certainly elevates it. Menstruation elevates it, certain phases of the menstruation. Pregnancy, benign ovarian cysts. So all of these are times when the CA125 would be perhaps inaccurate. Further, there are a lot of non-gynecologic problems that lead to an elevated CA125. Congestive heart failure, renal disease, liver disease, really anything that's going to inflame the abdominal lining is likely to lead to an elevation in your CA125. So that said, we're going to talk a little bit about how it has been used given the limitations that we know about. And again, I'm going to spend a little bit of time today talking about screening for ovarian cancer, since it is the area of such promise and that is really important, and since we do have new data to talk about. So to step back, what's a screening test? So the point of screening is to find disease in women who are otherwise healthy. We all do, hopefully, many screening tests. Hopefully you go for routine mammography. Hopefully you're getting routine pap tests if they're applicable to you. And the success of a screening test really depends on its accuracy and also on where you set your boundaries, right? So you all may know that CA125 test, generally speaking, the normal level varies, but is usually somewhere between 25 and 35. Now, if I set normal to 4, well, then it's true that I'm never going to have somebody who I cannot detect ovarian cancer, right? Everyone's going to have an elevated CA125, but there's going to be an awful lot of false positives. Conversely, if I set the level of discrimination to 1,000, so you only have an abnormal CA125, it gets up to 1,000. Well, yes, I'm not going to have that many false negatives, but I'm certainly not going to pick up a lot of people. So it's really important where you draw that line, what's normal and what's abnormal. And we call that a receiver-operator curve. The perfect test is always positive and never has a false negative. And that corresponds to this inverted L here. Chance alone, so a 50-50 shot in the dark, ends up being kind of this diagonal. And most tests are unfortunately relatively average, and they end up around here. And unfortunately, that's around where CA125 is. This is from a paper from 2011 comparing CA125 to 2 other possible biomarkers, HE4 and then a Roma proprietary algorithm. And the CA125 is in dark. I'm not going to talk too much about those other 2 tests, although we can if you guys are interested in questions. But the point is that the accuracy of CA125, as you can see, falls a bit short from the mark. So what does that mean? It means that CA125 alone is not going to be the ideal screening test. However, CA125 in conjunction with ultrasound and with clinical acumen may, in fact, be a reasonable test. So one of the main screening trials that was conducted in this country actually got reported in 2005. This is the Plco trial. This was a very ambitious trial looking at multiple disease sites, including prostate, lung, colon, and ovarian cancer. And the idea was to look at postmenopausal women who are at average risk and no personal history of ovarian cancer, and see if screening could alter their risk, right? So could we identify these cancers? So they actually found 78,000 women, 39,000 got no screening, and the remainder, 39,000, underwent routine screening. What that was a solitary CA125 and an ultrasound. It turns out that about 1.4% of the entire population had a positive CA125, so let's go back, and about 5% of the population had an abnormal ultrasound. And unfortunately, what this ended up meaning was that a lot of interventions were performed for women who did not need them. So approximately 570 women underwent surgery to detect 29 cancers. Some of them were not invasive cancer, they were low-grade tumors. And they required, to identify one cancer required 20 surgeries. So that means 19 women underwent surgery who would not have otherwise had surgery. And those women were, therefore, had a risk of complications and such that they would not have other had. So this was a cautionary tale and worrisome from a provider perspective that perhaps we're doing more harm than good. So we knew we needed to make a lot of improvements. And that was the next step, I think. Karen Liu and MD Anderson led a large collaborative trial looking at screening that was a little bit more sophisticated. And what they did was they put people into various risk categories based on CA125, but they didn't just use an individual test. It was a test over time, a longitudinal test that they put through a specific algorithm that they call the ROCA, Risk of Ovarian Cancer algorithm. That algorithm is proprietary, so I cannot tell you exactly what it is, but hopefully one day we'll be able to use it. So if your ROCA screen came back normal, then you just had another CA125 in a year. If you were at an intermediate risk, based on your ROCA screen. Then you had another CA125 in 3 months. And if you're at high risk, then you were triaged to an immediate ultrasound and evaluation by a GYN oncologist. As it turns out, only about 6% of people were triaged to the intermediate risk every year, and less than 1% of people were triaged to the high risk. So it was not overly burdensome for the patients. And what they found was that 10 patients, because of being triaged to high risk, ultimately had surgery. 4 of them had invasive ovarian cancer. 2 of them had low malignant potential or borderline ovarian cancers, and 1 of them had an endometrial cancer. So only 3 out of the 10 had benign disease. Now that's a reasonable rate, we think. Now, what's really exciting about this, except for 1, none of these patients had symptoms. So they really were caught based on the screening. Many of them had had many tests, so meaning they had gone through the screening for several years, and only after the 6th test or the 3rd test or the 8th test was something found. And many of them had really technically normal CA125s when the algorithm triggered and decided that they needed to be followed closer. So again, it's not just the specific number, but a change in that number over time that is more important. So this is from their paper, and this is one patient who was detected. This patient ended up being diagnosed with a stage 1C ovarian cancer. And you can see that initially this subject had normal CA125 levels. There was a slight trigger here, was rechecked, and then all of a sudden the increase, which was detected, and she was diagnosed at a stage 1. So a success story. More recently, a large trial in the United Kingdom was reported, and I want to review a bit more length. So this trial was a very ambitious trial, which took the ROCA screening algorithm and tried to determine whether or not we could save lives by using a similar algorithm of patients. So it was done in the UK. They randomized 203,000 women. Half of them got no screening, and then the remaining half were split into 2 groups. One did an ultrasound-based screening, and the other one they called a mixed modality screening, but that mixed modality was very similar to the ROCA algorithm, and they used the ROCA algorithm when they're determining when to have additional testing. You can see there's 50,000 women in each treatment group. So what did that mean? Well, the results were recently reported, and unfortunately, although there was an improvement in survival, statistically speaking, there was no difference between the screening group and the non-screening group. The rate of cancer in the non-screening group was 0.34% over the time of the study. For the ultrasound screening group, it was 0.31%, and in the mixed modality screening group, it was 0.29%. So although they were better, they were not statistically better. They have a very nice graph to explain this. So their analysis suggests that 2 lives based on those changes may have been saved with these additional tests, but because the statistics the power of the test was not strong enough, there's a range. So there may be no benefit, or the benefit may be as high as 4 patients' lives were saved. It's unclear. So additional time is needed to see what's going on. The critical issue here is that if you look at the rate of mortality over time for this study, there is a transition that happens around the 7th year after randomization, where there's an improvement. You can see how in the treatment or the screening arms, there seems to be a plateau in the risk, whereas in the no screening arm, the risk continues. And what the researchers think happened is that when they started this trial, there were a group of women who probably already had ovarian cancer, and they got randomized into screening or no screening. And if they already had cancer, well, the screening was not going to help them. It was too late for that small group of women. So they went on. But then as the screening continued, they were able to identify women and keep those patients alive longer and therefore change the curve. So had they prepared for this at the initiation of the trial, it would have been a positive study, meaning the screening would have likely shown a benefit. But they did not prepare for this from a statistical standpoint. And in the research community, we look very poorly on people who change their statistics after the fact because we're worried maybe they're cooking the books a little bit. So we take it with a grain of salt. But overall, I think these are very heartening results. And I think that going forward, use of the ROCA algorithm will show some benefit. So we also use CA125 not just for patients in screening, but for patients who come to us with a pelvic mass. So I tell my patients all the time, you know, ovaries make cysts. That's what they do. So if I took out every ovary that had a cyst in it, well, I'd be very busy. I may have a lot more money, but I wouldn't be doing any good. So we need some way to know which ovaries do we need to operate on when which ones need to come out. And the CA125 is really helpful in helping us triage that. There are specific guidelines that are in place to help us, and mostly to help general GYNs to know, when is this cyst complicated enough that I shouldn't be operating on this patient, I should send this patient to a specialist. And so the level of CA125 certainly depends on whether or not you're premenopausal or postmenopausal, as we discussed before. A lot of the benign conditions that menstruating women go through will elevate a CA125. So I need a really high CA125 to be aggressive in a younger patient, but it's still very helpful to know what that level is. These are happy ovaries. These are not very happy ovaries. You can see that. So that's what we're looking for. That solid tissue should not be there. And these are ovaries that need to come out. All right, so what about monitoring for recurring disease in patients with ovarian cancer? So if I asked this group, or many like it, how many of you check your CA125 on a routine basis, I bet most hands would go up. So I'm sure it would surprise you, perhaps, to see. So this is a relatively recent publication in the American Journal of Obstetrics and Gynecology. A group of expert clinicians from the Society of Gynecologic Oncology got together and looked at, in terms of follow-up, what evidence-based things should we be doing and what shouldn't we be doing? And when we looked at ovarian cancer surveillance, you can see across the board, CA125, optional. It doesn't say definite, it says optional. Now, why is that? There was another pretty ambitious randomized trial in the UK, led by Gordon Rustin, who wanted to know, how is CA125 helping my patients in surveillance? And this is what he did. He took around 530 women, and he randomized them to what he called early treatment or delayed treatment. So early treatment meant that you were getting your CA125 every 3 to 6 months, depending on how far out you were from your diagnosis. And if the CA125 was elevated, then you were triggered to get imaging, and if the imaging was abnormal, then you started chemotherapy. So that was the early treatment group. In the delayed treatment group, you still had your CA125 drawn, but you didn't know the result, and your doctor didn't know the result. So it was a double-blind trial. And so you didn't have a trigger to get imaging unless you had symptoms that were concerning for recurrent ovarian cancer. So, and when you did have symptoms, imaging was performed, and if there was something there, the appropriate treatment, chemotherapy, again, was then started. So what happened? So this is the survival curve for that study, and you can see the early is blue, the delayed is red. It doesn't really matter because they're basically superimposed, right? So there was no benefit to starting early by checking your CA125. And in fact, when they looked at what they used as a quality of life index, not surprisingly, Those who started early had a worse quality of life. Why? Because they were on chemotherapy for longer than the group that was delayed. So if I just said there's no benefit to checking CA125, then why do we check them? And the real reasons are there are several important limitations to Rustin's paper that make its applicability a little bit limited. The most important one, I think, is that the patients who were identified early were not given the opportunity for surgery. Now, we call that surgery secondary cytoreduction, and that's when we operate again to remove tumor to try to get to no residual tumor. To be fair, that strategy has never been proven in a randomized controlled trial. So we've never taken a group of women who did that surgery or gave chemotherapy and compared to see how long they lived. But we have a lot of observational data in the United States that says that if we are able to remove all the visible disease, then patients will do better. And so personally, I do offer secondary cytoreduction. I know everyone in the room does. So here in the US, we do strongly believe in it. And we know that checking a CA125 identifies patients earlier who may be candidates for secondary cytoreduction. And so that's why I personally continue to check it, although I'll talk about how I modify it. Other potential limitations. So the patients were given chemotherapy treatments that we might not have considered optimal in the United States. And so there's some questions of whether or not they would have done better if they were treated with different types of chemotherapy. And perhaps it wasn't fair to the stratification of how they did after their initial surgery wasn't done. And we know that probably the most important modifiable risk factor for how you're going to do long-term is how much disease is left after your first surgery. And they did not account for that in this study. So we actually did a small study at NYU. Many of you may have participated. I apologize. There was a survey study. So we asked our patients, so how do you feel about checking your CA125? And first we said, well, how often do you check it? And again, about 75% said they check it at every appointment. About 75% of them ask for the results every time after it's drawn. And most people think that it should be checked every 3 to 6 months. But then the understanding about what the CA125 can do, there were some limitations. I think appropriately people understood that it could detect a recurrence of cancer early and that potentially direct treatment early. But some patients also thought that it would decrease the likelihood that they would die from their cancer and decrease the amount of time that they would need treatment for their cancer. So that indicated to us that we needed to do a lot more in terms of education. And also, we asked, well, if we said we want to stop routinely checking your CA125, how would you feel about that? And most strongly disagreed with that route. So checking your CA125 level is not completely benign, right? So there is a significant amount of stress that can go around checking your CA125. I have many patients who are perfectly fine until the day before they come in to see me. And then as soon as I tell them their number's good, they're fine again. But that 24-hour interval is not a good time for them. And there are studies that have shown this clearly. So having stress about your CA125 has been linked to depressive symptoms. And that's been linked to the active monitoring. But increasing education about CA125, its limitations, and kind of the bigger picture has been shown to reduce stress and the depressive symptoms associated with that. So what does that mean? And I think this is kind of the most important thing you can do is talk to your physician about what's right for you in terms of checking your CA125. My general take on this if I have a patient who I do not think is a surgical candidate because of various characteristics of their disease, I tell them, you know what? I don't think checking a CA125 is right in your situation, and I don't think we have to do it. And I see that it's making you really anxious, so let's just stop checking it. And I have several patients in my practice who are very happy with this and who are doing spectacularly. Now, there are other patients in my practice who I mention this and they look at me like I'm absolutely crazy, and it's not comfortable enough for them to stop checking. And that's okay, but you have to have that conversation to see what's right for you. So, to wrap it up, CA125 is a very helpful but certainly imperfect test for ovarian cancers. I'll say for Dr. Levine is here. And we're not yet ready to screen healthy women, but we are getting awfully close. And so I think there's a lot on the horizon for that, and I think something is coming. Monitoring CA125 levels can be very accurate for some women, but not all, and may reflect recurrence. But remember, there's no proof that this extends life, and we know it may harm your quality of life. So do take the time to talk to your doctor about whether or not serial monitoring is right for you. Thank you. Appreciate the time.